Good morning. Before I don't want to take too much time. My name is Mahesh. I am the current chair of the scientific committee at the IOMP. I'm also a professor at Johns Hopkins University School of Medicine. I am a diagnostic medical physicist. I'm a low energy guy compared to the therapy, which is a high energy area. It is my great pleasure to invite all of you to this final webinar in this series of this International Medical Physics Week hosted by the IOMP. I would not take too much time otherwise to get started. For all those who are joining now, welcome from all different parts of the world. Please submit your questions in the Q&A. Chat is not the place to submit your questions in Q&A. And I, as a moderator, will keep a log of this question and prompt to our speaker to answer. We have a very exciting topic today, and the speaker has kindly agreed. He is Dr. Tracy Underwood. She is a radiotherapy researcher, and she has been she's worked at some of the most innovative clinics, and she is now working at the Christian Foundation, the University of Manchester. And she is now also have an appointment at the University of London College, and she is going to talk about radiation therapy, upright radiation therapy systems. And I'd like to welcome Dr. Underwood. The floor is yours. And so again, for all the audience from all corners of the world, it's a great pleasure to invite you to this webinar. Please submit your questions in the Q&A and we'll be able to answer them. Thank you. Dr. Underwood, it's your floor.
Thank you so much, Mahesh. Welcome, everyone, and thanks so much to all the organisers at the IOMP. It's been a truly fantastic series of webinars this week, and I'm honoured to be here. I work for a company called Leo Cancer Care, and we develop hardware for upright radiotherapy. I'm sure everyone here is familiar with the conventional paradigm shown here on the left, where patients lie flat on their backs and a large gantry rotates around them to deliver the treatment beams from different angles. These gantries are always quite massive. For photons, they weigh 6 tons. For protons, they can weigh 200 tons. And for carbon ion treatment, a gantry can weigh 600 tons. But does it make sense to rotate something that weighs 600 tons? Could we just rotate the person to be treated instead? So at Leo, we're developing an upright patient positioning system and a CT scanner to go with it, where the CT ring drops around the patient like a donut. I'm sorry, I seem to have an automatic slide transfer on here. I might just try and fix that if that's okay. Oh, maybe it is best to persevere. Apologies about that. I had some computer issues this morning and had to go to my husband's computer. I might just have to flick back between them. So yes, and at Leo, we're currently in the process of gaining regulatory approval for these two devices, the upright patient positioner and the CT scanner. And in the webinar today, we'll explore the opportunities and the scientific challenges associated with upright radiotherapy. So it's worth us noting that upright treatments were actually quite common in the 1950s all around the world. On the left here, there's an example of an electron linac from Hammersmith in London with quite a simple chair being used. And on the right, there's a composite photo from Canada showing a rotating chair, which was used with a Cobalt 60 unit. Similarly, one of the first photon linacs in the world in Stanford was used with an upright patient positioner. And Siemens even ran a training course on rotational irradiation at around the same time in Germany in 1950. So if upright radiotherapy was such a good idea, why wasn't it pursued in the 1950s? Well, shortly after that training course in Erlangen, rotating Linac gantries arrived on the scene. And these were, of course, super impressive pieces of technology. They were viewed as the must-have elegant solution. At that point in history, cancer diagnoses typically came later and patients were less fit. They were more likely to be bedbound. Perhaps immobilization was another problem that might have been deemed too challenging upright at the time. And then, of course, in the 1980s, horizontal CT scanners started to take off. In radiotherapy today, we all know that we're very reliant on information from CT scans, and having the patient positioned flat on their back for CT scanning really has made us reluctant to deviate from that position for treatment. But now in 2023, upright CT scanners are a reality. So on the left here is Leo Cancer Care's MARIE system, which has been designed to bring diagnostic quality CT to the treatment isocenter. And on the right, we've got a prototype from Canon Medical Systems, which has been used extensively in Japan for radiology applications, because it can be quite interesting to look at musculoskeletal loading, for instance, under normal weight-bearing conditions when a person's upright. So now that upright CT has really come into fruition, we should think about whether a paradigm shift is warranted towards upright radiotherapy. One famous figure in the world of the philosophy of science is Thomas Kuhn, and he has these 5 tests which he proposes to determine if a paradigm shift is warranted. There's simplicity, fruitfulness, consistency, broad scope, and accuracy. And I find it really interesting to think about how these tests relate to upright radiotherapy. First of all, if we consider simplicity. Over the years, we've rotated the beam around a patient using gantries for photons, protons, and even carbon ions. But like we've said, carbon ion gantries are truly enormous. To date, only 3 have been constructed in the world. And here's a brief video of the one in Heidelberg, rotating next to some people for scale. This gantry weighs 600 tons, it's 14 meters in diameter, it's got 75 kilometers of cabling. All in all, it's an incredible feat of engineering. But is this carbon ion gantry, which weighs the equivalent of 3 blue whales, an example of over-engineering? Even within a photon gantry, we're rotating a waveguide, magnets, voltage supplies, large cables, water pipes, beam shaping components, and so on. And this rotation, of course, leads to system wear and tear. Fixed treatment beamlines are clearly simpler and they're more robust. They can be made modular, so it's easier to upgrade them as new techniques come online, such as flash, that's ultra high dose rate radiotherapy. They've got simpler beam optics and more space, which gives us the potential to unlock improvements in physical beam parameters, such as proton spot size, for instance. And because they'll have simpler maintenance and quality assurance, fixed beamlines should also reduce expertise barriers. So in terms of engineering, there's no doubt that upright radiotherapy is a simpler solution. But what about Kuhn's next criteria for a paradigm shift, which was fruitfulness? Well, I'm sure many of you are familiar with the Bragg peak and the physical dose advantages of particle therapy. And of course, one of the main things that's hindered the expansion of particle therapy is the facility cost. At the moment, we've mentioned there are only 3 carbon ion gantries worldwide, and there are less than 200 proton gantries. These gantries are all several stories high, and they also require substantial concrete radiation shielding all around the room. In these schematics, the boxes give an idea of the room volume for carbon and proton gantries, including that radiation shielding. But Upright, because we're fixing the treatment beam, we predominantly require the radiation shielding in one direction only, and this makes the size of our treatment room much smaller and largely independent of the type of the beam. So clearly, reducing the room footprint should bring down the cost of construction, but we also expect upright technology to bring savings in equipment, maintenance, power, installation, and commissioning. And these sorts of cost savings will not only apply to protons and carbon ions, but also for conventional radiotherapy using photons. I think the challenge that our community should take on is whether we can halve the cost of a photon treatment room by moving to upright solutions. And globally, this could have a really tremendous impact. In the UK, where I am, access to radiotherapy is inadequate compared to the national standard, and this situation is reflected all around the world. Globally, 80% of cancer patients live in low and middle income countries, and these countries host only 5% of the world's resources. So any actions we can take to make photon radiotherapy more accessible have the potential to save millions of lives. Finally, when we're thinking about fruitfulness, if we think about patient throughput, the majority of patients with cancer will find it easier to walk into a room and sit down on a chair rather than getting themselves onto a treatment couch. And in radiology, it's been shown in Japan in the study by Jinzaki et al. That the workflows for upright CT scans are substantially faster than the workflows for supine CT. Similarly, we think that this will be the case for upright radiotherapy, so more patients should be able to be treated per day in an upright room compared to a supine room. The next of Kuhn's criteria for paradigm shifts was broad scope. Does a paradigm shift open up new horizons? Well, thanks to a partnership between LEO and a leading accelerator company called Mevion, it's now possible to fit an entire proton treatment system, that's a self-shielded accelerator and a patient positioner, into a LINAC vault. And on this slide, my boss at LEO, Nick Schroeder, has overlaid scale drawings of the Mevion and LEO combined system on a Varian TrueBeam. And I'm sure you'll agree, it's quite incredible that this system, including the proton accelerator, is smaller than a TrueBeam. And this means that for the first time, clinics have the option to swap out a photon system for a proton one in one of their existing treatment vaults. On the photon side too, it should be feasible in terms of both weight and size to put a shielded treatment room on the back of a lorry. This could take photon radiotherapy to rural communities, or it could provide a backup system when a hospital is commissioning a new permanent LINAC, for example. Upright radiotherapy also brings us scope for advanced imaging. Many of us will have come across the MR LINAC, and MR-guided radiotherapy becomes a lot easier and cheaper when you decouple the MR scanner from a large rotating metallic gantry, and it becomes feasible to have MR-guided proton or carbon ion therapy for the first time. Upright, we also free up a lot of space behind the patient, which allows us to put large detectors there, for instance, for proton or ion radiography. And on this side, by using the same particles that you treat with to image, it's possible to reduce the physical dose uncertainties in particle therapy. In the photon world, we've gained physical dose conformality by moving to arc-based treatments. And when we fix the treatment beam and rotate the patient through it, it becomes much easier to do arc-based therapies for protons and ions also. And particle arc therapy can give us the potential to improve treatment robustness and also to perform radiobiological optimization. Kuhn said that when assessing a new theory, that should be consistent with what we already know. And on a very simple level, we know that as humans, we spend most of our time upright. Because of this and the impact of gravity, we should expect some anatomical shifts when we ask a patient to lie down for their treatment. And on this slide, we've got some data from an imaging study which was performed at PSI in Switzerland, where the liver was found to drift over the course of around 35 minutes after the subjects lay down. It's possible that upright positioning will avoid some of these drifts, again, potentially improving treatment accuracy. Is radiotherapy upright consistent with what patients want? Well, these are results from a published study by Sophie Boisbouvier and her colleagues in Lyon. They worked with 10 patients who'd received conventional radiotherapy to the pelvis, and they set them up on the Leo Cancer Care chair. And the majority of these patients preferred upright positioning over the supine position that they'd received for their actual treatment. Similarly, we know that during conventional breast radiotherapy, patients are often uncomfortable both physically and psychologically. And on this slide, we've got some beautiful live drawings by an artist called Smiz, who also happens to be working towards a PhD in radiotherapy. Together with Smiz and Professor Heidi Prost from Sheffield Hallam University, we ran a workshop where we worked with 10 patient advocates who'd all received conventional breast radiotherapy. They gave us their views on a lot of different topics, but shown here are a selection of their views specifically on positioning. So if we go through some examples, there seems to be a power issue lying down. You feel so exposed. You can't get into position because of the pain. You can't lie flat because of the surgery. And an extreme one from one of the participants, I had heart palpitations at the thought of lying down. So many of these are psychological responses, but some of them are underpinned by physiological changes lying down. When you lie flat on your back, fluid gravitates towards your chest area, and this can indeed aggravate cardiac conditions and cause heart palpitations. Lying down can also lead to difficulties breathing, particularly for patients with lung cancer or patients with obesity. We have to also remember that radiotherapy patients are people, they're not computer models, and they come to us with their own stories and their own pre-existing conditions. And 3 conditions shown here, such as acid reflux, they all worsen when people lie down. So the last point on this slide is for patients with head and neck cancer, because we know that it can be very difficult for them to swallow. And again, this is something that's made worse when they lie down. The idea that patients are likely to prefer upright positioning on the whole is backed up by this study from Toot et al., which considered upright and supine positioning options for cardiac SPECT, and they actually found a strong preference amongst patients for the upright option. The next of Kuhn's criteria, is a new theory accurate? Well, to date, no treatment planning study has been published for upright and supine treatment plans, but we have quite strong reasons to believe that upright positioning will lead to more accurate radiotherapy for some tumour sites. For instance, it's well known that lung volumes are on average greater for upright body positions, as was shown in this quite comprehensive CT study from Yamada et al., again in Japan. So these larger lung volumes upright should lead to improved radiotherapy targeting in the chest region. For the prostate, at Leo, we've started to collect upright and supine MR scans for volunteers. And results from these indicate that the position of the prostate is largely independent of variable bladder filling upright, which again could lead to more accurate prostate radiotherapy. If we think about accuracy in terms of reproducibility and stability, we can refer back to the study I mentioned from Sophie Bois-Bouvier et al. In Lyon, where she performed upright setups for 10 patients who'd received pelvic radiotherapy using the Leo Cancer Care chair. She studied both the inter- and intra-fraction reproducibility for these patients using an optical camera system. And the results were extremely promising, especially as this was a world first to set up patients in this way. In my own research, I've worked with the team of Professor Heidi Prost to look at breast radiotherapy setups upright. There we found a couple of different specialized bras to be a really effective way of eliminating the inframammary skin fold. And we've determined that upright radiotherapy should also enable us to consider arms down treatment positions. And this is something that could bring increased comfort to a subset of patients receiving breast radiotherapy. Initial reproducibility for the breast is promising, but we do have some more work to do there, particularly as we look at stabilizing arm positions. So let's review those criteria for a paradigm shift. I hope I've convinced you that upright radiotherapy is simple, it's fruitful, it's consistent with what we already know, it has tremendous scope for new technologies, and the last of these, we're starting to build up a body of evidence indicating that upright radiotherapy is accurate. But of course, there's really a lot of exciting work to be done on this last one, which is why I'm so proud to be part of the research team at Leo. And we need help from the medical physics community to consider key challenges associated with upright radiotherapy as we go forward. So I'll touch on those key challenges in the last few slides. First of all, at the moment, upright image datasets are really quite scarce. We need to now be building up upright and supine MR databases so that we can conduct those treatment planning studies. One interesting question for the meantime is, can we build virtual phantoms to show us how internal anatomy changes with body position? For instance, if we consider the position of the heart relative to the breasts, how does this change as we move from lying down to upright positions? And then what happens if we move the person's arms? How does the internal anatomy change again? Sometimes in radiotherapy, it's really useful to incorporate physiological information from PET and MR scans into treatment planning. For example, oncologists might want to boost the dose to a really small but physiologically very active subregion within the tumor. How could we do this for upright treatments? Well, unfortunately, the most advanced forms of MRI, for instance, are not likely to be implemented upright anytime soon. So it would be really beneficial to perform research into supine to upright image registration. And at Leo, we're hoping to investigate possibilities on this with leading academic collaborators quite soon in the future. Challenge number 3, how can we keep upright patients comfortable and still? As we think about developing add-ons for our chair at Leo, such as new arm supports, headrests, and so on, we're working with human factors experts from Loughborough University to try to ensure that our workflows are as safe, comfortable, and efficient as possible. We're trying to design with, not for, patients and clinical staff, and we want to make our designs as inclusive as possible. The final challenge I'll mention today: how can we set up patients efficiently and accurately for their treatment when we consider that we want them to take on the exact same body position each day they come in for up to 30 days? How can we monitor that they stay still while the treatment beams are on? Well, to me, we haven't yet realized the full potential of optical camera systems in radiotherapy and 4D photogrammetry, especially with all the latest developments in computer vision and AI. I think there's tremendous scope for us to increase the use of cameras in radiotherapy. And we're lucky enough to have a project underway with Imperial College London on this. So historically, removing the radiotherapy gantry has really been seen as a compromise, not an opportunity. But to me, with the advent of upright CT, it really is a tremendous opportunity to move to upright radiotherapy. I think we can use it to improve the patient experience and to unlock new and exciting developments in medical physics and engineering. Thank you so much for joining today, for your attention. Thank you to the whole team at Leo Cancer Care, to our collaborators, and of course to my family. I welcome any questions, and also please feel free to reach out to me by email.
Thank you, Dr. Trace and Underwood. This was an excellent topic to discuss. I see there is a lot of questions. We're going to prep some of the questions because we have good time, and you can take your time to answer these questions. And because there is a lot of excitement in this new way of looking in. Let me start off with some questions. And I see some questions from some of the few same persons, or a couple of them very interested. Let me start with the first questions. Basically, we will try to capture as many questions as possible. Let me start with this one. First question is, how are children going to be treated? Because children often need anesthesia. So the question is, how children can be treated in this upright position?
It's a great question, and it's one we don't have the answer to yet. At least we're working on possible modifications to our chair to position pediatric patients, and we're also working with clinical teams to consider that question around anesthesia. There is some use around the world of anesthesia for other upright medical operations and so forth, but yeah, there's a lot of research to be done on upright pediatric radiotherapy.
The next question is, how can we shield or avoid the head when we do upright CT, since in some situation head should not be irradiated? They're talking about head CT. I'm not sure whether they're asking about the treatment, but can you take a stab?
Yeah, so I think the situation there won't be dissimilar to a conventional CT, that the CT ring will just cover the part of the anatomy that we're interested in. So I'm not expecting big differences there in the transition from upright to supine.
I understand. That's correct, because it's the same thing what we do right now. So we don't cover the head when we are doing a CT of the head up on the neck. So that's good. Thank you. Next question is the system which is described anything used with the new AVO proton radiotherapy LINAC in the UK? Somebody from UK asked this question. Are you familiar with the AVO proton radiotherapy?
Oh, yes, I am familiar with them, but we are entirely separate to them.
So it's completely different than what this company is different. So the question is, how far are you now in your center? Like, do you have a working prototype for the standing radiotherapy?
Oh, absolutely. We're currently working towards regulatory approval for our upright patient positioner and upright CT scanner.
So that CT scan is also for a radiation therapy treatment, or just?
Yes, it's designed with radiotherapy in mind, but like I mentioned, it's also of considerable interest in the radiology world, particularly for kind of joint issues. Sometimes radiologists like to see people standing or more upright with the joints bearing the load.
Okay, and it's not going to be a cone beam CT, it's just an X-ray tube and the detector rotating.
No, at the moment, our CT solution is full fan beam CT.
Okay. So the question next one is like, for what about treatment of some sites like breast cases, prostate and lung cases? Will you be treating this with the radiotherapy? I think you already kind of mentioned, but if you can elaborate, it will be very helpful.
Of course. Those are the three most common indications for radiotherapy right there: breast, lung and prostate. So we're devoting considerable research to them. We have in preparation a journal manuscript on upright breast setups, where we use these specialized bras to try and lift the breast off the stomach tissue to try and eliminate the skin folds and reduce skin toxicity. And those initial setups look really promising. So for all of those tumor sites, prostate, Sophie Boisbouvier and Leon has done a lot of work with our chair and demonstrated that pelvic setups are really achievable and promising. And lung, we anticipate kind of similar issues to breast, really, in terms of the treatment position and the arm supports that are needed. So certainly we expect our solution to be a really good option for those three tumor sites.
So as you're preparing now for regulatory permission, which particular organ or particular area you're focusing to start with? Is there any particular treatment you're focusing on?
Those three that we just discussed are really key ones for us. And then the next most important one would be head and neck, mainly because patients really struggle to swallow when they're lying down. And we think that moving them upright can bring quite a lot of benefit in terms of patient comfort.
The organizer, my colleague, Dr. Eva Bezak, has a question. Dr. Bezak, go ahead.
Thank you, Mahesh. Tracy, absolutely fantastic presentations. And all my students will have to watch it if they did not log in tonight. So I will be definitely downloading the recording. Question from my point of view. Have you considered pancreas? Some of the cancers that are very hard to treat and achieve, or not even being able to achieve tumor control. And me, from the managerial point of view, do you have an indicative cost of the system?
The pancreas one, I can try to answer. The cost one is trickier because, of course, it depends on kind of the local environment and exchange rates and all of this. So I won't even attempt the cost one. I'm sorry, Eva. But
no worries, it was worth a try.
For pancreas, I think you're absolutely right. It's a really difficult site to treat well. And there's been tremendous interest in carbon ion therapy for pancreas. But mainly carbon ion therapy is limited because centers without gantries use fixed beam angles, and they struggle to get a good plan. So having something like arc-based carbon ion therapy could be hugely exciting for these tumors that we really struggle to treat, such as pancreas.
Thank you, Tracy.
Thank you, Eva. I have another question. This is an interesting question. Does a LINAC in a lorry comply with the radiation shielding required?
Brilliant question. We've performed a feasibility study on the shielding that will be required and the kind of weight of that. and we think that it should be entirely possible to have a properly shielded system on the back of a lorry.
It's very interesting, but the other part which I liked your comment was, if this system is on the lorry, you can take the system to where the community is who does have very least amount of access to the radiation therapy. I think that's going to be a really positive one, because in the world, even in the developed or underdeveloped countries, the access to healthcare is minimized in the rural areas. I think this is an excellent one. And then again, the lorry can be placed anywhere in the center of a wheat field or somewhere in the stadium, and you can send the patient one at a time. I think this is an excellent idea. It's a lot of logistic, but I think it's a really good one. The next question.
I think we give
Go ahead.
Stress when we talk about putting a linac on the back of a lorry, and they think, oh, well, we have to perform quality assurance on it every day, and like, is it going to be a sufficiently stable system? But with hyperfractionation becoming more and more common, I think the idea would be more that you would take it to somewhere remote for like 1 week and give people 5 fractions over that week and then take it on somewhere else. So yeah, I agree, a really exciting possibility.
Yes. And if they had to do more QC, it's more good for the medical physicists, because more medical physicists will find employment with this mobile unit. Anyway, the next question is, what will be the typical dose per fraction delivered by this system?
Well, at Leo, for proton and carbon ion systems, we're not making the beamlines. That's by separate vendors. But all in all, we're not expecting that to be very different.
The other question is, shouldn't the criteria to choose a treatment modality be the clinical outcome? It's an interesting point.
Yeah, it's a really interesting point. And I think the patient has to have the final say on that. Like, what is most important to them? Is it the kind of maximum probability of tumor control, or would they really, really rather avoid a certain side effect? Or would they like a treatment position that they can tolerate? If they cannot tolerate lying down, then what can you do? So yeah, I think it's one that we need to kind of address as a multidisciplinary team and include patient views in that team. What is the most important outcome?
So the question is, can you compare your system to PCure system? And if you can briefly tell what PCure system is, that will help the attendees.
Yeah, so PCure are another company pursuing upright radiotherapy technology. In all honesty, I don't know a lot about the specifics of their system, so yeah, I wouldn't really like to comment on the differences there.
But PCure is another company which is also working on its upright system. Am I correct?
Yeah, they certainly have a chair, and they have some form of X-ray imaging system to accompany it, I believe.
Oh, wonderful. The other question is, my question about emergency patient is whether the upright patient upright position is beneficial for them, because it may cause them more harm.
I'm not sure I understand.
It's about emergency patients. I'm not sure emergency patients are rushed into treatment anyways. It's more like this question may be more appropriate to imaging part. So they're telling us, like, if what about emergency patients, is whether upright position is beneficial for them, or it may cause more harm. That's it. It's a general question.
Okay. Yeah, I think your point there is probably spot on, that normally we don't have those sorts of emergencies in radiotherapy. But yeah, it is conceivable that there are patients who this will not work for, who we cannot set up on the chair. But equally, there are patients who cannot receive supine radiotherapy. For instance, very obese patients can kind of exceed couch limits. And there have been cases where normal treatment centres have had to treat those patients upright by having them lean on the couch. So unfortunately, there's never one system that works for absolutely everybody, but we're confident that the upright system will work for the vast majority.
I think that leads to the next question, which is similar to one. It's an interesting question. It is seen that some patients lose weight during treatment. That is the supine treatment. What happens in accuracy and position of patients? Do you think that you don't have to demand them to lose weight if you're putting in an upright position?
I think there's no real difference for us there compared to the supine standard. Adaptive radiotherapy is becoming increasingly common, and it's the best way to deal with that sort of issue, really, is if you can adapt your treatment plan day to day to cope with any anatomical changes. And of course, in the LEO solution, we have diagnostic quality CT at the treatment isocenter. So we really have a nice potential to make adaptive treatment plans based on that.
That leads to another question. With this particular attendees is very excited about the upright radiotherapy. What they're asking is this mean we'll have a pair with upright CT scanner also? So what is your comment? So are you building a therapy with the CT scanner?
Sorry, it was the question like, is the
question is the upright system is also going to have a CT scanner attached to it?
Yes, that is the plan, that in most cases it will be implemented with the patient positioner, and the CT ring will drop down over that patient positioner.
So it's basically like a concentric rings coming inside and taking a CT, and then the ring will move out. Is that the way you're thinking?
Yeah, the ring moves up and down over the chair like a donut.
Understood. So that the CT scanner ring will move out and the therapy unit will come down?
The therapy unit will be more kind of in
fixed.
front. Yeah.
Or it will be, so the therapy unit kind of fixed, but the ring, the CT scanner ring will, like a Russian doll, rings come in and out.
Sort of, yeah.
It's a really nice one, yes. Let me see. So another one person is really find this your seminar webinar very interesting. The question they're asking is like, are there any limitations for treating around pelvis or lower limbs, as some of the positions seem to limit the beam entry, especially in the anterior direction where the patient is sitting? So how do you account for the table and other things?
That is an excellent point, and it's something that I didn't cover, that if you're in a seated position where your legs are kind of perpendicular to your body, you definitely have problems with beam access and the beams having to go through the legs. But with our chair, we can adopt what's called a perched position, which is much closer to standing. So the back of the chair is tipped down and the seat pan is also tipped down, and then the legs are brought down like this and kind of out of the treatment fields for pelvis.
Excellent. This is another question. Okay, this is interesting. So this attendee is already foreseeing this time when the system is going to be installed in the hospital. So the question is, if a hospital is to replace this existing machine with the suggested upright treatment, how does this fare for in terms of QA tools and procedure? Will the hospital can use the already acquired tools, or will they need to acquire new ones? So they're already thinking about what QA tools to buy. That's an excellent question. Yes.
Yeah, it's always great to think ahead. Really, we're anticipating most of the same tools. So you can remove the backrest from the chair, bring in a trolley over the base of the chair, and then your water tank would sit on that trolley for all of your commissioning measurements. So in terms of dosimetry, there should be no differences. In terms of mechanical quality assurance, there are, of course, some differences compared to a gantry, because you have to check the isocenter quality of the chair rather than the gantry. But there's nothing too challenging there in terms of QA differences. And because you're no longer rotating your treatment beam through all the different gantry angles, for sure your QA will be reduced relative to a gantry-based system.
That leads to another question. This is also very interesting. How do you treat patients that are body deformity, have in upright position, or how do you do that? If the patient, like a scoliosis patient, that deformity is there.
Okay, yeah, that is a really interesting one, because we've had a few volunteers come and try out our chair who they've had spinal surgery and other issues, and they actually find it really comfortable when it's used with a vacuum formed cushion. So that's our kind of normal solution, that we'll set them up with that, and that will obviously be tailored to the shape of someone's back, and it kind of aids with our reproducibility as well.
Another interesting question was already forethinking what happens. The question is, are we supposed to relearn everything in treatment planning and setup for both physicist and radiation therapy? So they're already thinking about, should we start doing some learning aspect for this new type of treatment?
Well, the good news is it's all the same principles, it's the same treatment planning systems. So research have already implemented upright treatment planning options. And as long as the kind of coordinate system of your upright CT is correctly interpreted by the TPS relative to the beam, there's really no significant differences around upright treatment planning. So everything you've learned supine will be applicable, and how to generate a good treatment plan will be exactly the same. The bigger differences would of course be for the radiation therapists or therapeutic radiographers who set up the patients. The workflow is going to look a bit different for them, but we're really trying to kind of develop those workflows collaboratively and make them as smooth as possible. So we hope that on the whole, there's not a significant amount of relearning that would need to be done. I think if you're an excellent member of clinical staff supine, you would also be that upright.
So this the next question is from the past PC chair of IOMP, and he's asking is like, since he has a lot of experience of treating numerous patients for upright for total body irradiation quite many years ago, the issue of comfort, patient comfort and reproducibility, they found it to be very complex. So how do you compare? In the past, that he has some experience doing this, but they found it to be reproducibility was quite complex. So
yeah, I completely agree with that. And in some of our initial work, we've taken supine immobilization devices off the shelf and tried to attach them to our chair, and that doesn't always work well. You need to be quite creative with this, and we're really lucky at Leo that we have both a human-centered design lead and a mechanical engineer who focus exactly on this. How do we make immobilization accessories so that we can keep a person comfortable and still upright? And we're doing a lot of work kind of proposing new armrest designs and so forth to do that. So I think, yeah, if you try to use supine solutions off the shelf, it can be challenging, but it's by no means an insurmountable problem. And if you adopt a kind of co-design approach, where we've even brought in physiotherapists to help tell us which body positions are kind of achievable for different people, and kind of really try to bring everyone in the right room to think about the immobilization problem, then we've made fantastic progress with that. And there's a lot of interesting work still to be done there.
This is an interesting question. The current conventional couch, we tend to move the tumor to the isocenter of the rotation of the treatment machine. Will this new system allow a similar approach, but moving the patient relative to the machine, or is there something more advanced by moving the collimation to achieve something similar? It's interesting. Whether do you move the patient or you move the whole system?
The plan is generally that it will be similar, that we'll move the tumor to the isocenter. So the rotating chair is on a platform which raises and lowers to do this.
And it also goes left and right in all directions, the table?
Yes.
So that you're aiming to position the patient treatment site as the isocenter.
Exactly.
Okay. The next question is let me see. Okay, these are a attendance question. We'll answer it after. Okay. Radiation delivery is with a fixed ring linac, but with the rotation of the patient. Is that what this question is about? How many degrees of freedom is possible with the standing patient support system?
The Leo patient positioner has 6 degrees of freedom, like we just got the left, right, pitch, roll, and yaw.
Okay, so the question they're asking is the radiation delivery is with a fixed ring linac, or is it going to be and rotating the patient?
Yeah, it's a fixed linac, so fixed treatment beam, and then the patient then rotates through the beam.
Understand. Okay, so the patient platform will rotate.
Yeah, the rotation is very slow. It's 1 revolution per minute. And if you try to do that yourself on an office chair, it feels incredibly slow. You basically can't do it.
Okay.
People respond really positively to that rotation. On the whole, they don't even notice that it's happening. It's a very smooth motion.
One other question is, can we deliver total body irradiation with upright position?
It's not something that we've focused on to date, but it's been done historically, and yeah, it should in many ways be easier than supine, I would say.
So, question here is one second. Give me. Some of the question is related to the CME, which we will answer separately. Can the desired beam characteristic be measured with the currently commercialized dosimetry system, or do they need to have a different dosimetry system?
I think that's the one we already covered, where we say, yeah, you take the backrest off and then you have a trolley to put your water tank on.
Okay. The other question is, I think you already answered the 6 degree of freedom on the table question. So in the current system, this is another question. There is a choice of non-coplanar beam direction. In a standing paradigm, would not the choices be limited to one plane?
Very interesting question. You've got kind of 2 possibilities there. Either you try to introduce a bit of flexibility in the beam line, so you have slightly different angles in your treatment beam, or you do that with the patient positioner, which we can do to some extent with our chair, but not a great deal. But my personal opinion is that non-coplanar fields aren't used very much in radiotherapy, and kind of with more conformal arc-based therapies, we're generally moving away from that.
The other question is, what do you expect in terms of reducing fixation devices and hence immobilization cost? Will it reduce?
Yeah, I think that is sort of open for debate, really. It of course depends on the vendors of the immobilization devices, and I think for both upright and supine there's probably scope to reduce the cost of accessories in radiotherapy, but it's not something that we've particularly explored to date, I would say.
Another good question, appreciating your presentation. I just want to express all those questions written by these attendees. Start off with appreciating how excellent your talk is. So just want to paraphrase. The next question is, do you think upright treatment could be better for patients affected by multiple myeloma?
Multiple myeloma. I'm afraid it's not something I know much about, so I wouldn't like to comment on that one. Sorry.
Okay. All right, because a lot of the time in the multiple myeloma patients also have very brittle bones and movement, other things. So, okay, I think you already answered one of the question: how to maintain the patient position? Can we use fixation system? That is like it. So,
yeah, there are a lot of options there. Really, in that study that was performed in Lyon for the pelvic patients, they added a belt, which the patient found quite comfortable and kind of reassuring. And yeah, we could add sort of straps potentially and the arm supports, like we've already mentioned. It's just a world of possibility.
yeah, another question is also interesting. Could the radiation be done with a tomotherapeutic approach instead of a fixed beam geometry? Like in the whole thing, the beam moving around.
Yeah, that's very interesting. Kind of swap our CT ring for a tomo ring with a person upright. Why not? I guess it would kind of increase the cost relative to fixing the beam though.
So this is another question asking is like, using a CT for imaging for positioning, how does this affect patient doses? And this is like all the imaging done with the therapy. The question is it going to change patient doses, increase or decrease or something like that?
I like that question because of course normally we have fan beam CT solutions in the treatment room, but actually fan beam techniques often lead to a higher, we have cone beam in the treatment room, and cone beam techniques often lead to a higher dose than the fan beam ones. So we're really hopeful that by having our fan beam CT in the treatment room, we can actually bring down the imaging dose.
So now the other question is how with the TPI case and a total skin case, total skin?
Yeah, that one we already kind of touched upon. It's not something we've looked into yet, but we don't foresee any big problems there.
Another question is, how can you achieve tangential beams in upright position?
Well, that one is through the patient rotation, that you do your first beam and then rotate the patient through 180 degrees and you would have the perpendicular beam.
Similarly, they're asking us, can we use wedges here?
There's a move away from wedges in linear accelerators generally, and yeah, that's not something that we'd be considering.
So another question is, says, horizontal position is the best natural position for any sick person, except in cardiac congestive state. For example, how would you require immediate? How do you immediately tilting of patient in erect position to horizontal position? Is erect radiotherapy or CT taking care of such emergencies? You know, we are doing upright and then you lay it down. That's the question. I'm trying to paraphrase the question.
Oh, so if someone has a medical emergency while they're on the chair, yes, so we are developing a kind of emergency evacuation procedure, and that would be kind of down to therapist training how to get them off the chair safely and onto a wheelchair, for instance. But I mean, it's also a challenge for supine radiotherapy, getting the patient off a couch that's raised up in an emergency.
I think you already answered this question, but I just want to repeat. Could you please comment on the treatment time? And since the patient is moving instead of the gantry, what will happen if the patient feels uncomfortable during the movement or something?
So the patient rotation is matched to the normal gantry rotation speed, which is 1 revolution per minute. So in terms of treatment time, it should be very similar. What was the second part of the question?
Like, will the patient feel uncomfortable when they're moving motion?
Yeah, so it's so slow at 1 revolution per minute that they'll barely notice it. In the future, there is a possibility for us to look at increasing that speed to reduce the treatment time, which could be quite nice for conducting a treatment during a breath hold, for instance.
So one final question. What is the SSD used here and how much we can treat at extended SSD?
Yeah, for a LINAC-based system, that can be quite flexible, really, like in terms of where you put your treatment head relative to the chair. So yeah, there's kind of possibility to change the SSD there.
I think this is we are top of the hour. I'd like to close it. I want to express my sincere gratitude on behalf of IOMP and myself for you taking the time to provide us this particular talk, which is really exciting as there are hundreds of questions. We try to answer as many questions as possible. With regard to some of the questions of this attendees question, there is a link in the Q&A area on the answer part. You can check that link before you leave the webinar, and you can access the certification for this attending this particular webinar and any other webinar you have attended in the IOMP. And this webinar is recorded and will be available on the website soon as we get to work on this and submit it. I think we had an excellent conversation, especially thank you for not only providing the representation, but also providing a lot of interesting questions, answers to a lot of interesting questions. Thank you, and I wish you and your group the best, and looking forward to see what the upright treatment center for in a city near me or something like that. Thank you.
Thank you so much for all the organization around these meetings, and to all the participants for their questions, which were absolutely brilliant and made me think a lot.
Yeah. Exactly, and I also want to thank the main organizer is Dr. Eva Bezak, and I was just asked to moderate this session, and I want to thank her also for forwarding. I also want to thank our Secretary General, Dr. Magdalena Stova, who maintains behind the scene all this recording very smoothly. And of course, I want to thank our President, John Damalakis, who is one of the main motivationers for stalwart behind this whole IOMP webinar and IMPW webinars. Thank you very much, Dr. Tracy, and good luck. Thank you.
Thanks, everyone. Bye.
Good night.